Screen to our legendary Dr. John Cole.
Well, thank you, Corey. Like you said, we have just about every time zone around the world covered here in this lab, this academy today. And I have a considerable amount of material to cover, and there's no way I can go into great detail on any of it because I have to cover it all. So let's begin with why we talk about regenerative medicine. You know, the President of the United States started losing his hair as a young man in his early 20s, and he had his first hair transplant in his 20s. Well, unfortunately, he didn't do anything to keep up with his hair loss, and gradually, the only thing that remains is a little bit of hair on the top of his head, and he's lost everything around it. So the concept is that we have to give our patients regenerative medicine. And if you've been in this field for 30 years like I have, what you see is patients who continue to lose hair over a 30-year span of time. And if you don't put them on something to help them maintain that hair, if you don't come up with a solution for them, what was a great result 30 years ago is not going to be a great result in the future. So we have the capacity today to regrow hair using products and regenerative therapy, which include biologics and cell-based therapies. And we never had this before. For example, this individual, I told him he was not a candidate for a hair restoration. And I've done everything on him, PRP, stem cells, from the adipose, exosomes, umbilical cord-derived exosomes, just about everything, laser cap. And what happened was he got better, and he started to grow so much hair that I added some grafts in there just to give it better color. So he got better right out to 21 months, and now I've moved quite a bit of hair on him. So let's just start with the basics. I've done a study, and I'm not going to go into great detail, but in this study, we looked at growth factor-rich mediums. And we looked at exosomes, we looked at platelet lysate, we looked at amniotic membrane, and we looked at adipose. And the first thing we discovered was that dermal papilla proliferation in the lab was directly proportional to the concentration of the growth factors. So the higher the concentration, the better the proliferation. So it's dose dependent. That's the first concept. The second is that hair loss is not a disease. It's an aging of the hair follicle. It's premature aging where the rest of the body remains young, but the hair gets old quickly. And so what's happening is the cells are turning over, and they reach a limit, and the growth cycles speed up, and the telomeres become shorter and shorter, and eventually the cells become senescent, and they just disappear. So when I was born, I was supposed to live to about 65 years of age, and today that is much longer. So it just keeps moving up. You know, the longer we're alive, the longer we're supposed to live. And there's this sort of epigenetic stress that maybe we can live an extra 35 to 40 years. Well, if you live 35 to 45 years longer, that means a whole lot of folks that are approaching 100 years of age are going to be bald. So the real complicating factor with the hair follicle is it's derived from mesoderm and ectoderm. And there's an interaction between various proteins that turn the cells back on. We've got the Wnt pathway that upregulates the follicle. We got the BMP pathway that downregulates it and pushes the hair into a resting phase and won't let it back out. So when hairs move from the resting phase into the growing phase, there's a proliferation of adipocytes, increased circulation, and neural tissue. And so there is an interaction between adipose and the hair follicle. We know that. The key to treatment here is to keep that hair follicle out of the resting phase, because what happens over time is that the cells will reach their Hayflick limit. And these are stromal cells. It doesn't affect stem cells in the same way, but the hair follicles will reach their maximum number of cycles. And as androgenic alopecia progresses, the duration of growing or anagen is much shorter, and the duration of telogen is much longer. And during telogen, there is inflammation that can attack the hair follicles. So we direct therapy at, first of all, reducing inflammation by keeping that hair follicle out of the telogen phase, but also stimulating that anagen phase. We want to keep that hair in the growing phase as long as possible. It's kind of like sending your hair to the gym. And that's the concept of regenerative medicine. We have pharmaceutical approaches, and we have cell-based therapies, which can be autologous, allologous, and xenogenic. Now, so we'll begin real quick with PRP, which was first described in 1998 by Robert Maxwell, who's a maxillofacial surgeon at the University of Miami. And he determined that the optimal concentration of platelets for him was 1 million platelets per milliliter, and that for his maxillofacial surgeries. So there is a correlation between the number of platelets and the concentration of every growth factor. The higher the concentration of platelets, the higher the concentration of each growth factor will be, and most of those growth factors are released within the first 10 minutes of activation. So in the studies I have done, I looked at products that delivered very high concentrations of growth factors like Angel Arthrex, and compared them to Regen, which delivers a low concentration of growth factors. Arthrex is probably in the 500,000 to 600,000 platelet range, but we get about a 50% increase in hair density at 6 months versus a 25% decrease in density with Regen. So the concentration of the platelets is very important in hair restoration surgery. And hair is not, it's not a tendon or joint or a muscle, it's a hair follicle. And so the concentration of platelets for hair is going to be different than the profile we might want to treat a joint with. Now, in all the products I've studied, there is a capture rate, and they vary. And I think Timur's going to talk a little bit about the T-Lab and the next PRP, which I don't have a lot of experience with, but I can tell you they have the highest capture rate I have seen personally. Capture rate is very important because the higher the capture rate, the more platelets, the more that we can get out of a smaller sample of blood. And so, as you can see, they're highly variable. Angel Arthrex actually has one of the worst, but it's a good PRP. So what I like to do when I'm treating hair loss, I like to hit that about 1.5 million platelets is where I want to be. And if I can be at 1.5 million platelets, I know I'm giving a very high concentration of growth factors, and then I sonicate the PRP. So I go from that 1.5 million all the way down to around 6,000 in this particular sample. So if the capture rate is 70% or 50% or 35%, where are the platelets? So I've analyzed it, and I can tell you there's platelets in every fraction. There's platelets in the PPP, the PRP, the red cells, and the buffy coat. And how did I study it? Well, I just ran everything through a Hemocult counter. And so if we include the buffy coat with MSite, we're going to increase the platelet count by about 2%. Okay, so that's the capture rate to go about 2%. So where are the platelets? Well, around 4% are in the platelet pore plasma. Then in the PRP and buffy coat, 70% with MSite, 8.86% are in the red cells, and that doesn't add up to 100%. So we don't have 100% capture, and we don't even know where, let's say, 17% of the platelets are. They probably clump, they got activated, or I think most may be sitting on the wall. And there's a concept that we might add some PPP into the tube prior to capturing the platelets, and that might increase the capture rate. Anyway, we have cytokine-rich plasma, which I call sonicated PRP or lysed PRP. And when platelets, you look what they do, first of all, they're going to clump, and that helps limit bleeding. But what they do next is they release growth factors to stimulate repair and healing. Well, we're interested in the growth factors, not really the clumping, when we treat hair loss. And what I've discovered is that the high molecular weight growth factors are going to be much higher, 5 times higher when you sonicate versus traditional activation with calcium gluconate or bovine thrombin or recombinant thrombin, based on my lab studies. And the kit is very important too. You know, higher concentrations of platelets are going to yield much higher concentrations of growth factors. And this stands true for all the heavy growth factors. VEGF is 21 kilodaltons, and TGF is 25 kilodaltons. But IGF is a low molecular weight growth factor, and so it will come out in a similar concentration regardless of whether you activate or sonicate. But high concentrations of growth factors can significantly increase hair density. But what else might they do? So I had this patient who had similar hair loss bilaterally. This is not a very common scenario. Usually one side's worse than the other. And I was able to place an equal number of grafts on each side. And what I found was that the hair grew in quicker on the side where I placed the sonicated PRP. And so then I went to the lab, and I studied cases where we placed 80 grafts in a 4 square centimeter box, and we found that at 3.5 months, the sonicated PRP had 89% growth versus the saline, which had 57%, which outperformed traditional activation of 73.5. So PRP does speed up the regrowth of grafts, period, and sonicated PRP, you'll have 99% of the hair growing at 4.5 months. So that's a big win. This is a study we did with Timur in Istanbul, and in it we compared PRPs from some other clinics to the T-Lab PRP and the next PRP. And we found that one of the kits, called the Vacusera, wasn't platelet-rich plasma at all. So this doctor brought in his kit, and he thought he was giving his patient PRP, but it was platelet-poor plasma. And the capture rate was only 4%. So, or 0.04%. Now, let's compare that to the next, 90.5% capture rate in that study, and the T-Lab was 77%. So these two have the best capture rate I've come across. What about individual growth factors? Do they stimulate the dermal papilla? Not really. Not really. There is a little concentration dependency, but individual growth factors don't do much. It's the entire milieu that's important. And they also, when you look at the one that does anything, it's insulin growth factor, which is very similar to, let's say, insulin in terms of how it's structured. Just briefly, I'll touch on exosomes. You know, you really need to look at the source. And the best exosomes are going to be T0. That means when the baby's just born. Umbilical cord, Wharton's jelly, amniotic membrane. And be very aware that companies will tell you they have so many billion platelets in their per milliliter or in their dosage. And most of them, you know, out of these companies that were studied, 3 of 5 did not have the dosage that they said they had. The other thing is you want to look at the size and distribution, okay? So there's a lot of impurities in most of the exosome manufacturers. In other words, they're not this really clear spike. And this is more of a pure exosome. And the other thing you want to look at is you want this particular spike. But how are the exosomes produced? You know, most exosomes, the cells are cultured in fetal bovine serum. And fetal bovine serum can have prions, like Jacob Creutzfeldt disease. So, you know, look at how they culture their cells to produce exosomes. Okay, so if we look at individual things, let's compare exosomes from bone marrow, which did nothing, amniotic membrane, which was quite good, platelet lysate, which is a top performer and very close to the positive control, and then adipose stem cell culture media had the best proliferation of all, and normoxic outperforms hypoxic. In terms of FGF7 production, which is a potent cell stimulator, the platelet lysate and the adipose are very stimulatory. So both of these products are useful to stimulate hair. But look at bone marrow-derived exosomes. You know, it's just not a good source, and it may not have been a good product. And this company, Direct Biologics, is no longer in business. But it didn't do anything in my lab. Now, what about adipose? This is kind of an exciting thing. Patricia Zuck discovered there were stem cells in the adipose back in 2002. And since then, the whole field of regenerative medicine has exploded with different ideas on what we can do with these things. You know, it's theoretical that we can turn stem cells into any tissue. And we can repair anything. Now, we know that when an organ is damaged, what will happen is the bone marrow will send stem cells to that organ to repair the damaged cells. And we know that adipose has much higher concentration of stem cells, like 500 times higher. And they're better quality stem cells. They have longer telomeres. So biologically, they're younger. And they have a great deal of more potential to treat conditions where stem cells might be useful. But let's think about hair loss. It's not really a disease, it's aging. So will stem cells help, or is it a secretome? I'm beginning to think more and more it could be the secretome. Just to let you know, with Gordon Saski, he presented an IFATS in 2022. He showed that in terms of hair regeneration, microfat plus stromovascular fraction outperformed microfat plus nanofat, which outperformed microfat. Now, this is an individual where I treated his crown with stromovascular fraction. This is an example of improved coverage in the perimeter. Now, I threw 1,500 grafts in the front. So while we're here looking here is the crown reduced in size. If you let the cells reach that Hayflick limit, you cannot bring the cells back. Hayflick limit doesn't influence stem cells, so it has to be other cells, or we're unable to turn those cells back on for other reasons. But if we look at some great results, if you combine platelets and pharmaceuticals like a topical finasteride with stromovascular fraction, you can get really nice responses. And, you know, I like to put stromovascular fraction in my areas where I'm going to graft. I think it's going to help improve the yield in general. So what about in scars? Well, in scars, you can do lipofilling, and you can add stromovascular fraction to help keep that adipose there. Now, there's some people that believe that even if you add the stromovascular fraction, the microfat will disappear in a year. But there's a great body of evidence from Aristodemus that if you combine SVF and microfat, you can prolong the survival of that fat, and at a year you'll have about 90% survival. So, you know, we go all the way from fat down to stromovascular fraction. We can do it through enzymatic digestion, which is frowned upon in most countries, and therefore we have to look at mechanical disaggregation. And, you know, T-Lab is putting on this show today, and they have an outstanding method of preparing mechanically digested adipose. And so what we want, we can create the stromovascular fraction and then take some of this cell aggregate and add it in, and it's a great adjunct to treat hair loss. But again, the question is it the secretome, is it the entire milieu, or is it the stem cell? So I've got this group of doctors. We kind of go around the world and we meet up about once a year and we compare things. And in this particular study, we compared the atomizer to the microlyzer in the tulip. And the microlyzer had much higher total nucleated cell counts, and it had a much better cell profile based on flow cytometry. So in other words, these CD markers or that are in green are the ones we want to see positive for stem cells. And the microlyzer had a very nice profile. You can see these little pellets at the bottom of these tubes. At the very bottom, you can see this little white clustering here. Those are all stem cells. So that's what they look like. They're probably 25 micron cells. And we count them. We got a lot of different ways of counting them. And we've compared a whole bunch of different samples. And the interesting thing is we might do one study and we get one count, then we turn around and do another, and we find that another product won that head-to-head challenge. So it's pretty interesting to compare the different means of mechanical disaggregation. Now, what about sources of fat? You're going to see more cells off the thighs, and you'll see the second most number of cells from the flanks, and then the lowest number of cells will come off abdominal fat. So this is a study done by Nathan Newman. It's unpublished, to be honest with you, but he gave me his data. And so let's talk about a couple of conditions that can be refractory to treatment, one of which is alopecia areata, and the other is scarring alopecias like lichen planopilaris. These are T and B cell mediated immunity conditions, and therefore they're treated with anti-inflammatories, including JAK inhibitors. Now, if you look at the JAK inhibitor, one of the biggest issue is a month's supply can run you $5,000 to $10,000, and you may not be able to get your insurance to cover it. That's in the U.S. So, you can treat both alopecia areata and LPP with JAK inhibitors. This is a patient with lichen planopilaris. He had a previous hair transplant, and he came to me to graft this area. He had originally had a strip done. So he came to me, and we started grafting his lichen planopilaris. And over a span of time, we were able to fill it in. But it took numerous sessions to get this to fill in and give him the coverage that he was after. And so I didn't see him again after 2012 until he showed back up with reactivation of his lichen planopilaris. So this time, I pre-treated the area with adipose. And the reason is adipose is an immune modulator. It will knock down the inflammatory process. So I was like, we grafted him the first time. It took us multiple sessions to get coverage. So this time, we grafted him and we added adipose, and we prepared it with the microlyzer. We got 3 million nucleated cells with 66.6% viability. Another patient I treated with, I prepared his transplant actually many years before, and then he came to me with this area of lichen planopilaris. Well, based on my experience with lichen planopilaris, I decided to pre-treat this with enzymatic digested adipose, and I used the Centrocyte 1000. I treated this area, and I grafted it 3 months later, and it all grew in. So pre-treating it with adipose may have improved the overall result. So it's something to think about to minimize the recurrence of LPP, but also to improve the graft yield in an area that is prone to activate and can attack hair follicles, including the ones you just grafted. Now, I knew from 2010 that we could get hair growth with PRP, but in alopecia areata, I had this patient who presented with a 2-year history of persistent alopecia areata despite treatment with all traditional methods. He was a medical resident at a hospital, so he had access to the latest technology. And he showed up. He had gradual improvement over time, but he still had this recalcitrant area. And I injected this area with adipose, which I prepared this time with the adenizer. I didn't get a real high cell count in that. It was actually one of the lowest I've ever gotten. But I injected it in there, and I added some PRP into my sample. And here you can see I used the adenizer, and I combined this with some PRP. And it's pretty common to add about a 20% PRP to your adipose. And I injected it. The area became a little hyperemic, and 2 months later, it resolved. So this area that had been there for 2 years, it filled in, and we solved this problem. So then I had another patient come to me with alopecia areata after I grafted him, and I filled him in over a period of years, and he had these horrible areas of alopecia areata. He showed up in August of this year. And in this particular case, I prepared his adipose with the tulip, and I injected it, and a month later, he was starting to show signs of growth. And I also added a little over 1 million concentration of PRP into that area. But unfortunately, 1 month later, it had spread to the top of his head. And I didn't treat this area. So had I treated it, maybe it wouldn't have occurred. I don't know. But at any rate, my protocol was to continue with the PRP monthly, and I was getting ready to give him more adipose when at the end of November, he showed back up and his alopecia areata had filled in everywhere except on top of the head. And you can see the dermoscopy, because these are white hairs. It almost looks like there's hair loss there, but there's not. The density is quite good, but it's all white. So this top area is actually starting to make a move just with the PRP. Not quite as fast as the areas that I treated with adipose and PRP, but it's making a move, and you can see the tattoo dots I've placed there now. I'm following these little hairs, and I'm following them with the Grow Track. And if he doesn't resolve this month, I'll inject it with more adipose in the top part of the scalp. Now, what about FUE? We create these wounds when we take the tissue out. These wounds right here, and they are going to heal with hypopigmentation. So I can't go into detail in this study, but I use an A-cell matrix stem, and I place this into these little extraction sites one at a time. And I've come up with a new protocol, as a matter of fact. And here's the little A-cell in there. And I did a study where I put a liquid bandage on, which I cured with a UV light. And I was able to follow these little places over a span of 3 months. And over that span of time, I noted that 58% of the extraction sites regrew at least one hair. So we knew we were getting some follicle regeneration. So what I've gone to now is I'm using the A-cell still, but I'm creating an albumin and PRF combination. And so you can see this yellow here. This is blood that's been heated 75 degrees Celsius for 20 minutes or 15 minutes, depends on the diameter of the tube you're using. And then you add some PRF to that to seal it, and that you activate with calcium gluconate, and it will form sort of a biodegradable bond. Now, we always want to measure our response to treatment. We have things like the hair check and the Levicam. We can actually go in and measure the number of hair follicles before and after. And the Levicam has kind of a nice feature, which is it's got a virtual tattoo system. We got the Grow Track, which will require tattoos, but they've got a nice little system where we can follow the amount of hair regrowth that we get in our areas. And it's a cute little camera that we put on a little phone camera. Now, what about injection depth? And I'm going to wrap it up real quick. Hair grows at an angle, and ultrasound has the highest axial resolution when you compare it to, CT scan or MRI. The ultrasound has the highest axial resolution. And when we go to 70 megahertz, we can actually see the hair follicle. And so we can measure its depth. If we know how long the hair follicle is, we can calculate the depth of that follicle. It's just simple trigonometry. The average follicle is 4.9 millimeters deep, based on my studies, which are a little bit more accurate than Paco Jimenez studies, where he did apometric measurements of hair follicles after they were stained or fixated. And tissue shrinks about 15% when you fixate it in formalin. So at 45 degrees, that 4.9 millimeter follicle is sitting at 3.46 millimeters. So what does that mean? You don't want to inject below 4 millimeters. You don't. And if you do, you're going to be below the hair follicle. So you want to be where those cells are. If that hair's growing at 30 degrees, you know, that follicle is really going to be sitting at just beyond 2 millimeters in depth. So with ultrasound guided injections, we can determine the depth we're in, and you want to be somewhere between the 2 to 4 millimeter mark, somewhere in that range. I'd say 3 millimeters is the ideal depth. Okay, and I think I could go into more detail, but that's plenty. Thanks.
All right, very nice. Thank you so much. Great presentation, beautiful scientific information, before and after photos. Very nice. Thank you. Thank you, Dr. Cole.
ForHair is run by Dr. Cole with 30 years of hair restoration experience, and we offer the most cutting-edge technology available. In fact, the ForHair Enterprise sub-company Cole Instruments manufactures custom-made tools and automated tools for hair restoration physicians all over the world. Our quality, expertise, and skills are superior to other clinics. Our reputation and results are the best in the world. It's time to restore your hair. It's time to choose ForHair.
We hope you enjoyed the video. Don't forget to hit the little bell button to get notifications of ForHair's video uploads. For online consultation, click on the link on the screen or in the video description.